Hello, my name is Dr. Audrey Cook, and with my colleague Dr. Jenna Ati, I'd like to introduce a procedure called transesophageal retrograde nasopharyngooscopy. We have no conflicts of interest. Access to the nasopharynx in dogs and cats can be problematic, and although we can often get a good view using a retroflexed endoscope, device angulation makes it difficult to perform targeted interventions. These images here are from an older dog with a nasopharyngeal growth and almost total obstruction of the choanal region. Our objective was to devise a safe and easy retrograde approach to the nasopharynx in dogs and cats, and to create nasopharyngeal access that would allow for effective interventions such as targeted collection of diagnostic samples, debulking of obstructive lesions, and removal of foreign material. The method described here is similar to an approach described by Derry et al. However, our method provides some significant advantages. We secure esophageal access using a sheath and wire, and this allows for exchange of endoscopic devices and use of other devices such as suction. Equipment includes a fluoroscopy machine, a suitable guide wire, a peel-away sheath and dilator, which should be at least 3 French wider than the flexible scope, a flexible endoscope, other devices pertinent to the planned intervention, and an esophageal feeding tube. The patient is under general anesthesia and in right lateral recumbency. The left cervical region is prepped. The long guide wire is then directed from the nostril to the oropharynx. On the fluoro image here, we can see the wire traversing the lesion and heading down the esophagus. The wire is then retrieved and pulled from the mouth. If the nasopharynx is completely obstructed and cannot be traversed, simply skip this step and move to the next. Grasp the angle tip of the guide wire with curved forceps. Direct the forceps into the cranial esophagus. A sterile assistant then feels for the forceps and makes a small incision over the tip. The wire is then retrieved through the incision and the forceps are removed. The wire now extends from the nostril to the cervical incision. The peel-away sheath 20 or 26 French with dilator is placed over the cervical end of the wire. Both ends of the wire are held firmly under tension to facilitate placement. In these images, we can see the dilator and the sheath being directed over the wire and into the nasopharyngeal region. It is really important to keep the wire taut to make sure that the dilator stays on track. The dilator and sheath are hubbed, and we can see on the fluoro image that the device is positioned appropriately. Remove the dilator and secure both ends of the safety wire using clamps to prevent inadvertent displacement. The flexible scope is then inserted through the sheath adjacent to the wire. On the fluoroscopic images, we can see the safety wire traversing the nasopharynx and the scope sitting above the soft palate. On the endoscopic view, we've pulled back the sheath and are looking towards the nasopharynx over the soft palate with the endotracheal tube heading down the trachea. The safety wire is visible at the top of the endoscopic image. Post-procedure, retract the sheath caudally until it falls below the soft palate and redirect it into the oropharynx. Pull back the safety wire from the nostril into the sheath, redirect it into the mouth, retrieve the oral end and pull through a substantial length of guide wire. Place the feeding tube over the wire from the neck to the mouth and then direct the oral end of the wire down the esophagus and into the stomach. Direct the distal end of the feeding tube down the esophagus, again over the wire. Remove the peel-away sheath and position and secure the feeding tube in the usual manner. This is the patient shown at the start of this video. She underwent piecemeal polypectomy. On the right side image, we can see a 10 French red rubber catheter is now easily traversing the nasopharynx from each nostril. These references are pertinent to the work shown here.